Well, thank you. First of all, I want to pay homage to the Godfather, Dr. Barsan, who continues to be a role model and mentor, I know, for me. And even though he's much, much older than I am, my goal is to be enthusiastically engaged in the research process when I reach Bill's advanced age. So again, thank you for all you've done. I'm here to tell you about the work of a whole lot of people, MCIRC, the Michigan Center for Integrative Research and Critical Care, but I want to set a quick background about why we developed this multidisciplinary center. When you ask people what cancer is, the civilians or hospital administrators or people in psychiatry, they know what cancer is, right? They know someone who's had cancer, they've seen a St. Jude's commercial. When you ask people what critical illness and injury is, you can sometimes get that deer in the headlight look, even hospital administrators. So this is really just a reminder about what the face of critical care is. It's a whole lot of things that have in common that we have to diagnose and treat them very rapidly. And look at the numbers. The numbers are really immense. They take a huge socioeconomic toll on the healthcare system, but we've really not moved the dial very much. So I would challenge anyone to say that there's really been any game changers in technology in the last 20 to 30 years. I know in my practice, the way I view it, I don't see any big game changers. So again, similar to cancer, lots of specialties that practice cancer. We have lots of specialties that practice critical care, including one of the newest, emergency medicine. And we've got lots of critical care units, including the nation's first critical care unit in an emergency department. So when you look at all this from a hospital perspective, it accounts for nearly 40 to 50% of all hospital costs are critical care related, and between 40 and 50% of all hospital days. But the commensurate investment is really not there given those numbers. So MCIRC was really meant to be developed to sort of move the dial by doing some big, bold things. So integrate non-traditional partners, so sort of integrating across the medical specialties, but enabling that with our colleagues in the College of Engineering and Public Health and Nursing, leveraging big data. So there's no bigger big data challenge than that in critical care. I'll mention that in more detail in just a few minutes. Develop strategic partnerships, so engaging industry very early on so we can be one-stop shopping, and reduce the energy barrier to multidisciplinary and transdisciplinary care. And so we've done some things, we'll review some of the exercises we've developed to help move that forward. So in a nutshell, this is what MCIRC is. So we've taken all those critical care presentations of the face of critical care. We've overlapped all those critical care specialties. We've overlapped all those enabling disciplines, including engineering. And we've really done something unique involving industry really, really early, so that if we do this often enough and really in a strategic manner, we can hit that sweet spot in the middle and develop those game-changing technologies, whether it's a therapeutic, a diagnostic, a piece of digital health, or a healthcare model. So if we do this again successfully, we can develop platforms that speak equally to these two patients. And so you look at these two patients, this wounded soldier on your right and this sick neonate, 500 grams in the palm of your hand, and you say, what do they have in common? They have tons of things in common from a pathophysiologic perspective. They're at risk for pain, for bleeding, for brain injury, for infection, for lung injury, and their providers have similar challenges. So think about the challenge of taking care of that little bit of real estate in the palm of your hand when taking a cc of blood would mean that you'd have to give that baby a blood transfusion. Or the combat medic who may have to take care of 15 wounded people and all he's got on his back sack, or to help those people, is what's in his back sack. All right, so he'll make some bad decisions that may cost some lives. So this is my go-to slide with engineers, for example, and those outside the house of medicine. So it's about winning hearts and minds. All right, so we're the smartest people in the world here at Michigan. They work on whatever problem they want. Our goal at MCIRC is to convince them that critical illness and injury is worthy of their talents. So this is some things we're doing with big data. So anyone want to guess how many data points per second would be coming from this ICU patient? Okay, 100,000. Okay, there is no bigger big data challenge, and so we can only keep track of a couple of things at one time, right? Much less 100,000 data points per second per patient in a 20-bed ICU, or the chaos in the emergency department. So MCERT came together with some partners around the medical school to develop a big data platform, and it's actually right down the hallway. And right now we're streaming every bit of data there is from 175 ICU beds in the hospital. So these are waveforms, images, the EMR data, the text, everything there is. And we're doing really uber data mining to develop pattern recognition algorithms that can tell us, for example, give us early warning in terms of an event. So whether it's acute hemodynamic instability or whether you're developing ARDS days before it occurs. So one example of this is an analytic called the Analytic for Hemodynamic Instability. So this is an analytic which just takes a single lead of ECG data and pulls out features that are invisible to the naked eye. And we're running this on patients, and we've got a cohort of patients, for example, that we predicted acute hemodynamic stability 4 to 6 hours before it happened. All right, so that would be very useful, and that's something that could actually scale at home. So the idea here is that you would have artificial intelligence running in the background. So whether it's in the ICU, telling you which patients to see when to avoid catastrophes. This would reduce sort of the alarm fatigue that we all experience. But again, this could easily scale to home as well through wearable sensors. So again, that's the work of a lot of people, and this is sort of an example of how we sort of get the tribes together to do this. So one of the first things MCERT did is we had a Sepsis Grand Challenge as a day-and-a-half event where we got 70 engineers, data scientists, clinicians together. We went over what sepsis is, what our wish list, what we think the gaps are. We heard from engineers in terms of what their skill sets were. And then we threw $300,000 on the table and said we're going to fund 3 to 6 projects. But the key is, in order to get that funding, there has to be a PI from medicine paired with a PI from engineering. And that caused a lot of indigestion, all right? But we funded 6 things, and 3 of those things are making their way out to commercialization. So you guys have heard about the TBI Grand Challenge through the generous gift of the Massey Foundation. So this is another great multidisciplinary exercise. Friday is Shark Tank. And we're going to fund we have $500,000 on the table to fund 4 to 5 innovations that could change the face of traumatic brain injury. So I'm going to go through a quick list of projects. And again, these are really multidisciplinary. This is a non-invasive tissue oximeter that clips on to your cheek, and it shines a laser at your buccal mucosa and gives you the chemical fingerprint of oxy and deoxyhemoglobin. And that value is more or less the exact same value as you'd get with a central venous or mixed venous saturation. So this is being tested. This was funded by the Navy, but it's actually being tested in several neonatal ICUs around the country. It's getting ready to start trials here at Michigan as well. This is a project that Nick Theuni and Ross Kessler helped us with, developed by Hakim Tiba, who's a research scientist in emergency medicine. So this is an impedance device. It sits on the arm. Blood is a good conductor, so when there's lots of blood there, impedance is low. When there's less blood, impedance goes up. And so we're treating the limb here as an extension of your vena cava. And so we can count respirations. And when we ask a patient to take a deep breath or to breathe through an inspiratory impedance valve and measure the inferior vena cava at the same time, we've come up with an algorithm where we can take that impedance data from the limb, and it's essentially identical to what the IVC collapsibility index is. Okay, so this is something that's really scalable. It's not going to put ultrasound out of a job. Don't panic. Those of you who are in the ultrasound fellowship, you'll still have lots of good things to do. But it's a good example of this is more or less a continuous way to look at IVC collapsibility index. All right, it works well on mechanically ventilator patients too. This is a new sensor here. It fits around your finger, and it's measuring the energy produced by the expansion and contraction of your digital arteries. And so you get this really beautiful waveform, and we're using that waveform to predict. So that's the morphology and shows us the compensatory mechanisms of the vasculature. We're using this actually to predict hypotension as well. Okay, so you could look at these as new sets of vital signs that would really inform us. Again, non-invasive. We're actually studying this in the dialysis unit to help predict intradialytic hypotension before it occurs. But we're using the dialysis setting to help inform us before we start trialing this in the emergency department or critical care unit. This is a really no moving parts, miniature 1 drop of blood thromboelastography measure. So if you've heard about thromboelastography, it's whole blood coagulation, which lets you take a look at the onset of clotting, the actual strength of the clot, how fast the clot lyses. Those are things you can't get from a PT or PTT. The current devices are really expensive, like $60,000. You can only run a couple samples at the time. This is a disposable 1 drop of blood. You can see that blood contracting there in the video, and it gives you the exact same information as the more expensive TEGs do. This is the world's first redox measurement. So you know where pH is all about protons, redox measurement is all about electrons. So this is the balance between oxidants and reductants. So it's like almost a free radical meter. You could never make these measurements in the past because of biofouling of blood on surfaces. But we've overcome this. I mean, this is again a great collaboration between material scientists, electrochemists, and intensivists to develop this. So this could be a new biomarker in terms of when is your resuscitation actually complete. We're actually using this to look at the health of stored blood, and we're finding that some of the blood in the blood bank is not really healthy at all, which could explain some of the storage lesions that we experience. If you were going to take, this slide is actually to sort of reinforce the notion of how no stone is left unturned. So we will aggregate lots of those things I just showed you, for example, and we're working on a project to actually redefine sepsis, right? So using these new vital signs, these new biomarkers, we may uncover that there might be 5 or 10 phenotypes of sepsis at one time. And so this really gets to the heart of the precision medicine effort and how we can make barriers or break barriers in that regard. We have a group here that does automated image analysis. So across the hallway here, we've got groups that are developing algorithms that automatically read your CT and identify injuries, right? So a whole abdominal pelvic CT, we can identify the fractures there, where the bleeding's coming from, and we've got TBI algorithms as well that can identify the hematoma, the midline shift, and estimate what your intracranial pressure is, for example, okay? Great stuff. This is one of the projects being put forth for the Massey Grand Challenge. This is using impedance through the eyes to look at cerebral autoregulation in the brain. So again, blood's a good conductor, but this is a great way perhaps, and we're finding in our animal labs that things you guess would be going on in the brain based on high blood pressure, low blood pressure, high ICP is not really reflected in autoregulation. This is a kind of a simpler project. So this is a chemical oxygen generator that mixes a dry substance with water and will produce 6 liters of oxygen for 20 minutes. So the goal here is maybe to put these where you would find automatic external defibrillators, but also use these in austere environments around the world to reduce deaths from neonatal and maternal hypoxia. This is a simple project. Again, one of the Masseys, you've all heard the term permissive hypotension. It's nice to instruct medics to practice permissive hypotension in the field, but we give them no tools. This is a blood pressure device really will inflate to your minimum target blood pressure and track the pulse ox. And when that pulse ox signal is lost, you know you're below your minimum threshold pressure. Okay, not really high tech, but would make a huge difference for a combat medic or for a prolonged transport in the field. You know, we all know in the trauma bays, even the blood pressure reports that we get out are very suspect, very suspect. So this combines photoplasmography with blood pressure. This is non-invasive REBOA. So this is something we're going to undertake with the Army, where we're actually developing a device to compress your aorta from your stomach, okay, or your esophagus, basically. So this could actually be done in the field. This is our attempt to make the ICU bed more than it is. So 6 weeks in an ICU bed on a ventilator, you won't be able to walk when you get out. So this is a collaboration with mechanical engineering and a bunch of critical care specialties to actually do rehab in the bed. So we're going to use acoustics and sound, and this is equivalent to passive and active range of motion. And so the idea is no matter how sick you are, we're going to start your precision physical therapy so that you're healthier when you get out of the unit. Simple airway device that would clip onto your endotracheal tube if you're unsuccessful. So if the tube's in the esophagus, don't remove it. No fear, M-Circus here. You're going to actually clip this on, and it's going to blow up a balloon around that endotracheal tube. So not everything is really high-tech. This is innovating back to the future. So there's going to be probably a call to put out tourniquets widespread for civilian use because of the Boston bombing and other things. But if you put on a tourniquet, it's very, very painful, all right? So we tasked some engineering students to come up with the best tourniquet design you could, very comfortable so that people could use it, and without pain, so even elderly could use it. And they came up with this design with blue, but it's actually a Civil War tourniquet. Okay, so going back to the past, but it is great. I've used it on myself. Never has ischemia been so comfortable. We're almost done here. So even this is bringing back the iron lung here for ventilation. So think about this as an adjunct to non-invasive ventilation, or even for positive pressure ventilation to reduce peak pressures. Also to leverage negative intrathoracic pressure to reduce intracranial pressure. So we have some projects there. We're multidisciplinary, so this is the leadership here of MCIRC. So it's spread across lots of disciplines, including engineering and basic science. We have core assets, the big data platform. We've got an awesome large animal ICU. We've got a proposal development unit, which really makes it easy for many disciplines to get together and do large proposals. We've got this large innovation portfolio and a Catalyst core that does strategic management of projects end to end. These are some of our outputs. We've got 140 members from 6 U of M schools. About 20 to 30% are from the College of Engineering. We've got a great communication network. We do things like Innovation Underground, where we go for bourbon and beer and talk about ideas. Some of our best stuff has come out of those meetings. We are developing and cultivating these foundational research communities around sepsis and TBI. We've got people studying sepsis and TBI now who never studied it before, but they're hooked on it, and that's going to be great for our patients. We're doing all the publishing, but over 40 patents and invention disclosures. Almost all involve collaboration across the 2 schools. With the largest number of innovation grants. We're doing a really good job engaging industry. Industry has shied to make critical care their business model, and we need to change that. So in the future, this is what we hope to do through MCIRC and this Uber collaboration. Maybe reduce mortality from sepsis by half, hemorrhagic by shock per half, double the survival rate from cardiac arrest, and good traumatic brain injury outcome. So anyway, that's in a nutshell. Lots to do. We covet your participation. If you're not collaborating, my message for you is if you're not collaborating, you're not being all that you can be. All right? Thank you.